Hey y'all, happy Baby Friday. I am pleased to have my really good friend and colleague Sonal Patel with us today to do our quarterly E&M question, query, update, whatever you want to call it. So, welcome back again, Sonal.
Hey, Betty. So good to see you. I know it's been a minute since we've been on together, but it's our favorite topic, right? The E&M coding stuff. So thanks so much for having me back.
Yes, love it. Oh, and for everybody today, please don't forget, is the 1 year anniversary of Hurricane Ian when it came through and destroyed everything around me. So
Yeah,
there are a
your
lot of
house.
people, they've had
Yes.
specials on the news down here that there's still a lot of people that don't have homes and not in their homes. Luckily, we're almost all the way finished with recovering. So at some point today, just kind of give a little thought to those people would be appreciated. So see, we have a lot of people in here today. Annette and Lady, of course, was one of our first people in. So hey, Lady.
Hey, lady.
We have Teresa Kelly. So hey, and Erwin Duran. So and Jeanette Hayes. Hey, Jeanette. We are going to get into our E&M stuff and talk first about some of the updates that we saw in the proposed rule. Some of the things that we saw, like the time issue, I've got a little slide for everybody that has the adjustments they're going to make for the time for the office visits for next year. It's not really an adjustment, so don't freak out, but it's just the way to kind of move it around. And also, Sonal and I are fixing to speak next weekend at a couple different events. So I wanted to also put some information up about that to give you all time to kind of look at things. And one is at the Orange Irvine local chapter. Sonal, myself, and Ray Marie Jimenez from AAPC are going to be doing a workshop with the Orange Irvine chapter on E&M on leveling, auditing, and compliance. So we kind of split it up. Ray Marie is going to work off some notes to work with the group on leveling. Then I'm going to talk about auditing the records that that everybody was looking at and different kind of tips about auditing in general. And then Sonal's going to kind of wrap it all up with talking about the compliance end of things as it relates to those notes and to other things too. So we're very excited to be speaking again together at something. And lady who is on with us today is one of the officers of that chapter, and she has very nicely agreed and has offered a discount for anyone who wants to attend that workshop. It's October the 7th, so it's a Saturday. And she put here for everybody two times in both Pacific and in Eastern time, so you can kind of adjust your hour plus, hour minus, as you go across trying to figure it out. But I will put in to the LinkedIn chat a link for Eventbrite for tickets if you would like to attend that one, with a discount for $15 off of the price of the workshop if you would like to attend it. So thank you, lady, for offering that for everybody that is on with us today. I think it should be a really fun and good event. Sonal, do you want to say anything about like what you're going to kind of concentrate on that one?
Yeah, absolutely. So big shout out to our very good friend Lady for inviting us in the summer to come and speak at this event next Saturday. So super excited, right? It's a great, great topic that I know we've been speaking around the country for a few months now on the topic, because we do still see a lot of issues, right, in our new 21 office guidelines. So yeah, hopefully I'm going to try and wrap things up with these notes that we have to use in terms of examples, right? So how to audit them, how to be compliant, tie it all up with a bow in terms what we need to be seeing in this new landscape, this new standard for E&M today and moving forward, of course, until the next changes roll around, which be sure to expect them from years.
Yeah. Hopefully not for a little bit with E&M, right?
Well, not the overarching overhaul, right? But in terms of like more teaser questions from our providers as well, right? The AMA is definitely going to continue providing more and more guidance for us in terms of just CPT things. And then I'm sure on the back side of that, CMS is going to have more and more details come out from the various MAC platforms as well. And both are often quite different. So from a compliance standpoint, we have to be mindful of both CPT and what CMS is saying. So just things like that. It's going to be quite the day of an event. So hopefully you guys can sign up and attend and hear some pretty phenomenal speakers in the industry trying to teach, trying to advise how to do things correctly and appropriately the first time.
Yeah. And Lady just reminded me, well, all of us, as you put in here, that this discount on the link that I put up in there is only good for today. So if y'all are thinking about going and want to use that discount, it's $15 off of the price. So make sure that you go ahead and book your ticket for it today before today is up. So again, Lady, we really appreciate that from the chapter. Lady also did give me a free admission for someone. And so a little bit later, so it gives time for everybody to get on, maybe about halfway through, I have a little trivia question in my head that I will ask, and whoever answers first in the chat is the person that I will give that to. And they can just kind of message me, because I don't want to put that link out there, of course, because then, you know, it's only good for one person. So we want to make sure the right person gets it. And then the next place where we're going to be, both of us happen to be on the same day.
On the same day.
Twice is for the St. Louis local chapter. And they kind of have their fall into the revenue cycle seminar going on, and that's going to have various different people speaking on different topics. So the one at Orange Irvine is directed toward E&M, you know, and this one for the St. Louis chapter, we got Stacy Buck, who's speaking on IR coding, interventional coding. She's, you know, one of the queens of that. Jennifer McNamara is going to be talking about some ICD-10 stuff. Also from AAPC, Caitlin Brack. Dr. Wolf is going to be talking about thinking like an MD for MDM. Now in that session, I'm going to be talking about MDM for E&M, and I have created a little coding game, and we'll kind of, you know, play with that during my session. And then Sonal, you're going to be speaking on maintaining compliance again, but now on a different kind of level, not just directed toward E&M, right?
Exactly. Yep. But again, compliance. Yes.
And then Vanessa Moldovan, who I've had on my program, and I know, you know, someone, you know her. You've probably had her on your podcast, yes?
She needs to come on my podcast.
Yeah, Vanessa, you have to.
We just figured out that she's recently moved back to the Chicagoland area. So we actually need to do a face-to-face here sometime soon.
Yes, I'm jealous. And she'll be talking about denials management. So a little bit of a plethora or a cornucopia of topics that will be on that one. And so on the flyer here, there is the registration information. And anybody that's interested in either one of them, if you cannot pick up on the stuff that you need off of these, just message me and I'll send you the flyer separately, or maybe I'll post them just generally out on LinkedIn so that, you know, everybody can see it. And, you know, if there's one that you are interested in attending. So that is our fun stuff coming up next weekend. So I just wanted to get that out there for everybody. Oh, Thank you, lady. Both of us are rocking it on that day. So I don't know, rocking it. I know we're going to be,
I don't know about rocking it, but we will be on.
be nuts. So good. So now on to our subject for today. We're looking at our E&M stuff. And before we get into some questions, one question that somebody asked is kind of off of the Federal Register, the proposed rule stuff. So, but the AMA put out the notice for, the CPT finalization for next year. One thing I do suggest for anybody, I attend the CPT symposium. I really wish they would do it back in person again, but they still haven't. This year is still going to be virtual. When they hold it live, hopefully, I don't know, maybe next year, I don't know what they're waiting for, but it's always in Chicago because that's where the AMA is headquartered. So I'd like to go back, to have a visit, because then Sonal, you and I can have an extra visit with each other too.
Sure.
But it's in November, and they go through and have the people that are on the CPT editorial panel talk about the CPT codes that are for their section and why the codes were made. And they show sometimes images of the procedures being done and why they had to have a new code for it, and how the RVU structure is for the code. And, so you get a lot of deep information, more so than you would get just looking at the CPT book or looking at the Insider's View book that they put out. And then on top of it, some of the MAC directors for CMS, for the MACs, they're also there. And then they'll come on after the physician speaks about the new codes. They'll come on and talk about, here are some of the coding billing issues that we see with this, or where there may be things to watch out for, or where they don't agree with something CPT has said, which also can be kind of interesting. And then you get to ask everybody questions. So I think it's really, really good if you've never gone to look into it, to see about going. I already, purchased my thing, so I've got it blocked out on my calendar. I think it's November 16th and 17th and 18th, or 17th, 18th. It's around in that time. If you go to the AMA's website, or Google CPT Symposium, it'll take you to where you need to look, and it'll show you the agenda. But one of the things that they are changing for E&M is the office visit time criteria. In the past, that they've had, everything was always in the ranges, so it's 10 to 29 minutes for this and 30 to whatever minutes for that. And then when they did all the changes in 2021, 2023, when they made everything like thresholds. So there's just like a cutoff time. So no more will they have their ranges. So Sonal was nice enough to, because I couldn't put my hands on it, Sonal was nice enough to send the graph here that shows how they're changing it for next year. So as you can see, 15 to 29 minutes, now it just says they have to meet a threshold of 15 minutes. And so for 99203, instead of 30 to 44, then it says the threshold is the 30 minutes. So starting where that lowest level is. So this is just something that, so that's the, if you want to say, biggest change. And that's really not something different. It's just so that it matches all the other E&M codes that now have threshold times. So thank you, Sonal, for sending that over to me so that I could share it with everybody.
Yeah, absolutely. Absolutely. We did have to do away with this time range in the office section, since in 23, right, everything was just truncated to the, we must meet this minimum threshold or we can exceed the time. But it can't be under the threshold that they've identified. So, if your provider is documenting 13 minutes, we can't be using the level 2 because you're not meeting that threshold of 15 minutes. So there are ways that we can tweak and make sure that our documentation is compliant if we're choosing to use time moving forward. Yeah.
Yep. Good. So I just wanted to share that. So that's something to Sonal or I, or probably both of us will end up posting that too. So people will be able to look for it. So you can see some duplication there of issues, just to make sure the word's getting out, right?
That's right.
Now, in the Federal Register, when they were talking about E&M, one question that we did get from Stephanie was on the G2211 code. So I want to kind of get into that. And I had to split her question into two different screens because I can only do so many characters in one. So we'll have to have two to get to the whole thing. But she said, can we provide some guidance Thursday on that new, or it's not a new code, but it's been a bundled code prior to now. It hasn't had a value to it for Medicare. The G2211 doesn't appear in the proposed rule that it really addresses when it can be used. So will it be all levels of E&M? Can it be reported with prolonged service? How often can it be utilized? Can it be reported on the same date of service with different specialties? So Stephanie had quite a few questions on it. Now the G2211 code, and I should have put that in a banner too, but I'm sorry, I forgot. It is a code that's kind of supposed to be an add-on code. Here, in fact, the definition, the descriptor of the code is a visit complexity inherent to E&Ms associated with medical care services that serve as a continuing focal point for all needed healthcare services and or with medical care services, this is a long descriptor, that are part of ongoing care related to a patient's single serious condition or a complex condition. So it's an add-on code that you would put on top of the E&M code. I think, and Sonal, give your thoughts too. I think initially they put it out to kind of give primary care a little bump when they're seeing patients with single complex conditions, because a lot of our primary care doctors, of course, are seeing patients for multiple chronic conditions at a time. And so I think it was a way for them to try to give them a little extra bump when they're treating those patients like that. But when they put it out there, then the questions started coming about, well, it doesn't say just for primary care. So that opened the can of worms. And because when they initially put it out, they actually had in their mind that it would be used this certain percentage of time. And because of budget neutrality, that affects what our conversion factor and what our values can be for other things, because we have to be budget neutral. I hate that, but they have to do it. So if they pay more for something here, they got to take away from something over there. And so they found that they really didn't think that portion of it through so much. And so then it became a code that, we couldn't use. So then they talked about it now for 2 years, right?
2 years. Yep.
So the last thing that they came out with from the Federal Register this time is they believe now, with it being able to be used by anybody, they didn't restrict usage. So think about oncology, think about cardiology. There's many specialties that could be using this add-on code. I don't think it's only going to be primary care. So I think their latest thing was they think it's going to be reported 38% of the time with E&M codes. That's a lot. So,
of course. Yeah. I mean, because, based on the descriptor of the code itself, it's definitely going to be used for those patients with, more grave concerns. Absolutely. And that's our patient population, right? For oncology, cardiology, et cetera, all of the higher level specialties. So I thought it was a really good thing that the AMA came out and wrote that huge, 200-page response in regards to the proposed rule, right? And they had concerns that we need more precise definition and, who can actually be using this particular G code finally, right? Because it's been around for a couple of years. And when they establish RVUs to it, it can be used. So, on the show today, we can't really provide Stephanie with any definitive answer on guidance for the code, because you can't really use the code. There's no definitive RVUs that are assigned to it. It's just theory, and you can read lots of articles in the industry for who wants to use it and why. But for now, these are just talking points and opinion pieces, right? Mm-hmm. So they did somewhere, I believe, release that they don't want to see it used with an E&M and the modifier 25 for things like that. So that's one clear no-no that they've already provided some more issuance for us. But in terms of anything else, in terms of specific providers, et cetera, no. And the public comment period just closed right now on the 15th, right? So we have some time for them to wait and digest and incorporate all of those public comments, which hopefully a lot of people have contributed to. So
yeah. In the Federal Register, in the proposed rule, I'm sorry, they first thought it would be 30%, 38%. Now they think it's going to be 54%. Now that they've added in the other specialties and really thought about it, so they actually bumped it up, which is even like way more than the 38 at the beginning. But in there it does say if you're going to use modifier 25 on an E&M, you can't use it with that then, because they're already pulling out something that was bundled into something else, so they didn't want to kind of add on top of that and that it would get too confusing. So Stephanie, the only thing we can tell you at this point is that you can't use it if you have an E&M with modifier 25. But they are not restricting it by specialty. So, and now I don't recall, because part of her question also was about prolonged service. I don't recall reading anything about prolonged services. So that I can't speak to. Did you see anything, Sonal?
Same, no.
Okay, all right. Let me see, we got some. Oh, Angela has up here that the AAFP has a good page on the G2211. So people, if interested again in that, I think it's a good code to be checking out, because there will be a value to it come January 1st, 2024. We just don't know what it is yet, but there will be an RVU value to it. So you will be able to start using it. So you'll make sure, whatever kind of information you can start to kind of glean from different places, make sure you're checking it out. I mean, especially family practice, but other specialties, as we were mentioning, you're not going to be restricted from using it. So understanding it will be good, because we definitely want to get, especially it's not looking good for our conversion factor, right? So you'll need to be able to capture all revenue possible. And if this is a valid code out there that, has some nice RVU value, even if it's not that much, over the course of patient after patient after patient, that stuff starts adding up. We need to capture everything we can compliantly, of course. And Beth's on. Hey, Beth.
Hey, Beth.
Sonal just got back from speaking at Beth's latest retreat that was in New York. So Beth, I hear that everything was nice and good with that retreat. So Beth's next retreat is going to be in October next week in Prescott, Arizona. So yes, we're very pleased. Both of us, Sonal and I, both spoken. I did the one in San Diego, and Sonal's actually did the last one in New York too. So that's really good. She's those are something you want to go check out on Advanced Coding Services site. Check out her retreats there. Angela, she loves to. That's what we're all here for, is for sharing the knowledge, right? So as we pull up different questions, y'all too, if you have other questions, make sure you're throwing them out there for us so that we can kind of pull them in and answer them as we're going along. But one of the other questions that I have seen a lot about is about that split shared stuff, because the split shared, I don't think they can make their minds up with that thing. This reminds me of when ICD-10 was going to go live. Do you remember we had everything set and ready, and then they were like, well, maybe we'll wait,
We'll wait.
and then, oh, we're going to go next year. Oh, maybe we'll wait, so it's the same thing with the split and shared stuff. They just can't seem to make up their minds how they want split shared visits to be done and when they're going to just cut it off, and say, this is it. They currently have it to where you can do it either by who does one complete key component, history, exam, or medical decision making, or who spends more time, the physician or the APP. And then they had decided that this year it was just going to be the most time. And then they backed off and said, well, no, we'll let you still do both ways. And then it was supposed to be next year they were going to cut it off. Well, they still are going to let things fly. They don't know what they want to do with it. So you just have to keep paying attention if you do split shared visits. First of all, what I want to say about that is, remember, split shared is not for the office. I keep hearing people question about, well, it doesn't apply in the office. In the office, you would be using incident to reporting. That's it. If you're doing like where they're saying, but split shared is only for when they're in the inpatient, in the facility side, seeing patients. So get the office stuff out of your head. That now I was on Novitas or Novitas, however you want to say it. They officially call themselves Novitas because they say it like 90 times when you listen to anything they're presenting. But I was listening to a thing they had on E&M just last week. So this is something at least I can talk to about this issue. The question came, well, we don't really have key components as described in how the code sets used to be under 95, 97 guidelines. So when they talk about being able to do it as who's completing one entire key component, how should we be looking at that if there aren't key components necessarily with the boxes and the click off points and all that junk? So I can tell y'all, the lady from Novitas that was speaking answered the question in this way. She said, even though there's technically not key component requirements, such as, a problem-focused history, blah, 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 like that kind of thing, there are still key components because you have to do a medically appropriate history and a medically appropriate exam. So the key components still exist, just not in that counting manner that we had them prior. So according to Novitas, now y'all might want to check with your MAC if your MAC is not Novitas, that since the requirements are no longer there, whoever says they have done the complete history or the complete exam or the complete MDM would be able to say they were the main person. So if you see in a note where the APP goes in and the APP documents the whole history from the patient, whatever the patient says their story is, the physician then comes in later and, just goes on to do the exam, the medical decision making. Well, you could then give it to the APP because the APP did the entire history, no matter what that history would be. No counting, no whatever, but they do the entire history. Then they can get credit for that visit. If the physician comes in and the physician does the complete physical exam that they think is medically necessary, then they can claim the visit. So it is up to what they think is the medically necessary history or exam. If either one of them completes that in its entirety, they can still count that as being it done in completeness. So they're really not saying you have to say so much or you have to cover so many things. They're kind of leaving it out to kind of whatever you feel is the necessary thing. If you do all of it, then you can claim that visit. Any comment on that? So it's still kind of convoluted, I think. It's still an area where if it gets audited, from a compliance standpoint, this would be a question that just hit me. Would you think that it would be safest then to say because, you know, the physician coming in probably is going to give a little bit of history, or is going to say he read the APP's history, right? So when the APP does the history, would you think it would be best practice maybe for them to make a statement then that, you know, I completed the entire history?
Exactly.
What do you think
Exactly.
about that?
Yeah, exactly. We have to be able to create different language in our EMRs today in this new landscape, right? We have to be able to craft those sentences that identify who did what for the majority of the time, right? And then even if the MD comes into the room, piggybacks off of what the NPP did, that's perfectly fine as well, because then the MD can definitely have a small statement as well saying that they agree with the history that they just reviewed, that their APP performed, right? So there are ways to ensure compliance in this, agree with you, that's a great word, continued convoluted landscape that we're in for this one particular area of split shared. I wish they just bite the bullet and make it
I know.
easy and just, you know,
Yeah,
pick one.
just in time. Let's go. You
Let's
know,
just
let's
go
just
with
be done
time.
with it.
Yes, and let's be done. Instead of teaching it this way, then teaching it that way, and then just fingers crossed, we're still waiting, right? So yeah, so there's no definitive guidance, but there are ways to ensure that you are protected a bit better when you are drafting your documentation. Do it better for the current landscape that we're in, and be done with the old ways that are still in the EMR that Betty and I see every time we're auditing. We're
Yep.
still looking at outdated EMR templates.
Yep. Yep. Full blown key component things that,
Full blown, I reviewed
30-point
13
review
systems, blah,
systems. I
blah.
was like,
Yeah.
oh,
You
come
don't need
on.
to review all of that body. You don't need to review them that intensively.
And that's a good point. When you were talking about that with the EHRs, that could be a good thing with a template to have a box check. You know, I completed. You know, I did the complete whatever. You know, one under the history, one under the exam. Whoever did it can check it. You know, and then you've got the documentation to back it up if it gets questioned by a payor. So that's a great idea, Sonal. And who Angela says, when are talking, you know, looking in light of healthcare groups and systems, looking into AI to improve efficiency and compliance. Clean, clear, concise documentation is crucial. Those AI things, you know, unless it's exact and it's repeated over and over, sometimes the AI doesn't know what to think of that stuff. And then it starts giving you answers that are really not that great. So, you know, speaking of AI, you know, I mean, it's just a tool. It's a tool like any other tool we have. So if you're given a bunch of garbage and putting it out there, it's going to see all that garbage, and that's what it's going to put in its brain. So it's going to start giving you garbage. You know, so I was one of my new clients. I was at there yesterday, and they were talking about stuff, and he says, "Yeah, they call it GIGO now, garbage in, garbage out." So he was like, "Yeah, no GIGO, no GIGO." And I'm like, "Okay." So that's what it's going to give you. So very good point there, Angela. Thank you. And again, if y'all have other questions as we're going through the ones we got, make sure you put them in the chat so we can hit them with the time we have left. Let's see. So, minor versus major. That's another question that we see a lot too, right? Because in the MDM table, you know, it just says minor surgery, decision for minor surgery, decision for major surgery. And traditionally, you know, forever, you know, everybody pretty much goes by Medicare, you know, by Medicare global days, 0, 10, or 90. And when these new MDM tables came out, the AMA kind of made it a point to say, and I think I remember at the symposium on that year, somebody had asked about the major versus minor thing. And the AMA's response was, don't forget that what you're asking me about, that 0, 10, and 90 global date, that is a payor issue. It's a billing issue. CBT is not a billing book. CBT is a book for us to explain the services we're providing. So the AMA does not buy into the 0, 10, 90 kind of rule and looking at procedures. So to the AMA, they said it's a major procedure if the physician says it is. You can't go by, they don't go by what CMS has put down as the minor and major global days. Examples, we were looking, if you look in fracture care, right? Every fracture is considered a major procedure. So if somebody breaks their pinky or their toe and they just buddy tape it, those are considered 90-day global. So are you going to tell me that's a major procedure? They don't take them to the OR. They don't do, it's like, here, I'm going to splint that finger for you. And now we've got 90 global days. So that's decision for a major procedure. There's, you could kind of argue against that, versus somebody in the cath lab that's getting stents and all that. And those are zero global day procedures.
That's right. Yeah.
So
these new guidelines, right, really open the auditor's mind. Like, we have to think critically, right? Whereas we didn't used to before in 95, 97. We were just little robots that just thought everything was a major surgery because we followed CMS, right? We have to think critically in this new landscape. Yeah, just because it's a 20,000 series of CPT codes for a fracture, and because CMS says so, that it's 90 days, no, when you break your toe or your pinky finger, a physician, an MD, a DO is not going to be like, oh, that's a major, repair that I'm doing, for this tiny little bone. No, yeah. So the new AMA way of thinking, is in the very basic definitions to a physician, to the actual practitioner of what the definitions of major and minor actually are, right? So we have to be able to, implore our providers to think that way in this new light and not go by what we've all been so very, very used to in the past from 95 and 97. Things have totally shifted. And I think it's a good thing.
Yes.
We start to actually look at the language for the language itself, and not the surgical global package. No.
And again, on that theme of the best practice idea, if they don't stay in the note, major versus minor, most policy, and I would suggest you make a policy that the assumption would fall back to Medicare's global days, but you want to try to get them in the point of stating it. So another templated kind of thing, major procedure, minor procedure, let them tick it off, and then you get their thought process, because unless they're stating it in the note, you're not going to be able to tell. And a payor, of course, is going to default to, whatever behooves them better. And
exactly.
whatever they're trying to pay you or not pay you for, right?
Yes.
So yeah, that's the kind of thing with the major versus minor procedures. So try to get the physicians and APPs in the practice of stating, the patient needs a major procedure of an endoscopy or of an open repair of something or whatever, or because of the patient's risk factors and things like that. Maybe the patient's 95 years old. Anything you do on them could be considered major, I would say, right?
Absolutely. Yes. Right.
So yeah, listing those types of things out, that's what it's all got to be. If they think it, they need to ink it, right? That needs to get into the note to where it is seen by the auditor, seen by the payor auditor, especially if you want to keep that money for those services that they're doing.
Absolutely. Absolutely. Yep.
And then we have a question here, or a statement kind of, on medication management from Kelly. She says, just because meds are listed, what are you actually managing? You can't just say meds reviewed with no additional continue meds, anything like that. Yeah, I would say nowadays, this was something they're trying to address with that whole pull forward, the EHRs that pull forward the last and the last and the last, to where you look at something and it's, like 20 things long, and it's like, I haven't taken that for 12 years,
Right.
So yeah, just saying meds reviewed does not say you're managing anything. You're just reviewing it. You looked at it. I mean, yes, it proves you looked at it, but it doesn't state that you did anything about it. You have to show you're managing it. So definitely make statements in there that their levothyroxine is at the appropriate level, so they will continue on the same dosage. That's not just saying they're reviewed. You're showing you managed it. You looked at it. You looked at the patient's condition. You thought about it, and you said, oh, the level they're at's appropriate. We're going to keep it. That's managing it. It doesn't have to be that you add a new medication, or I get some people that think that that's what has to be done to count it. But if you are saying you're going to continue at the same level, if you're stopping a medication, again, the thought process had to go into it, right? So that all shows that you're managing prescription drug medication. So it's not just starting a new med, but you do have to expressly state it. That whole review meds thing is not good. So you have to make sure you're taking that one step further. Oh, Bertram is joined us too. Hey, Bertram, how are you?
Hey,
Good to see you.
Good to see you here. And absolutely, even the thought process of why you're discontinuing a medication, that counts, right? But we have to paint the medical picture. We have to understand why we are discontinuing it, right? What is the risk this drug dosage is posing to the patient? So we have to stop it completely, or we need to tweak the dosage to benefit the patient, right?
Yep.
So there's ways to massage our documentation, how to better capture the verbiage in this new landscape is key, because we're done. She and I see the laundry list all the time of the medications. There's 25 drugs. We know the patient has discontinued those meds ages ago. But again, because the EMR system does it no current justice, right? So it's all just pulled forward, copied forward again and again. And so when auditors like us come in, we cannot identify what are they currently managing, right?
Yep.
Unless we have those amazing practitioners that we get to talk to and say, hey, you followed our advice, you tweaked and massaged your language, bravo, because now we understand what drugs you're using and managing today and treating the patient today at this encounter. So kudos. But those are few and far between. We need to see more current documentation to meet the new standards.
Yeah, I love it when I see the meds list and the same medication will be on there 4 different times at 4 different dosages, because they've changed it in the past and it never goes off. So it's like, well, which one are they actually taking?
Exactly. So there was a problem in the past in the EMR ages ago as well, right? But again, it's still being copied forward, dragged forward again and again. So
Yep. And so the statement, continue meds prescribed. Again, I think you're in a gray area there where you could say, my opinion on that would be we need to be more robust with it. But if you have, I have had compliance counsel that have said, well, I could defend that, because if you're saying continue the meds prescribed, that means you didn't just review them. You looked at them, you thought about it, and you said your decision is to continue those as described. So that one, you could push back with that as a good statement, but I would always suggest, and this is me, that gets improved a little bit. Sonal, your thoughts on that statement?
I agree that counsel can definitely see defendability in that truncated statement, but auditors and compliance professionals like Betty and I would prefer to see an additional word or two, right? We're not suggesting volumes of additional words that are added there. A word or two can make a world of difference. And then that could be, used when the case applies, patient by patient. It becomes habit, right? We have to retrain how to document today and stop using the outdated methodologies from 95 and 97. We have to do so much better because there's so much more scrutiny that our providers are in today. So.
And we have let me go back. Where did it go? Here from Maria, do we have a list of medications that are considered high toxicity? I know there is one of the payors that does have a list where they have listed some high toxicity medications. I can't think of it off the top of my head, but I will later come back into the chat and post a response here to you, Maria, of who that is. Sonal, do you know? I can't think of it
off the top of my head, but
there's there is a payer that has a list, but there's not like a magic total list anywhere that like an auditor like Sonal and I would go to and go, oh, here's my list. And the thing with that is just because it's on the list doesn't mean it's always considered the high toxicity monitoring, like Coumadin, warfarin. When you put patients on something like that, you really have to monitor them closely at the beginning. But if everything gets straightened out, then it's like once every 3 months. Well, if it's once every 3 months, that's really not intensive monitoring. So just because a drug hits it once doesn't mean it always hits it. So that's something to be mindful of. You have to take it in context, which, as coders, a lot of people kind of look for, give me the answer. If I see this, I can say this, but we all know, especially with E&M, it is just not always that way. So I will, Maria, though, find where that link is to that payor that has a list, and I'll come back here and post it later so that you have it. And then so everybody else can see it too. But yeah, just remember in context, you have to be looking at those things. Same thing with one of the other questions that we got was about the parenteral or parenteral, however you want to say it, controlled substances. Someone was asking, well, I don't understand what they're talking about with those. If they say it's a parenteral controlled substance, that means that it's given other than through the alimentary tract. So it's not an oral medication. It's not given rectally. It's not put through a feeding tube. It has to get into the body, usually by injection or infusion is how you're going to see those drugs given. And then they should be usually a controlled 2, class 2 or 3 controlled substance. And here is, I put together an example of a couple, of the drugs that would meet this, like diazepam, fentanyl, ketamine, morphine, but again, remember, not given orally. So that's your first caveat, is you have to see how it is being delivered. And then, is it considered a controlled substance? There are some sites where you can check for specific drugs to see if they're controlled substances. And I will, once again, go back later and put those in for y'all, because I had them, but they're like, so I didn't have time to cut and paste them into the chat. So I'll put them in there for y'all later to look at and see what is considered a controlled substance. And then you make sure that you are looking at the method of delivery and seeing that it's not through the alimentary tract. And then that would meet what would define for the parenteral controlled substance. Oh, good. Angela, thank you, Angela. It was Palmetto. So Palmetto has a list of drugs for high toxicity. So thank you very much. I appreciate that. So y'all can go check that out. And again, remembering that it has to meet that for that time, it's being intensely monitored. So, but wonderful. I really, really appreciate that. And I want to remember, because we're almost at time already. Can you believe that, Sonal?
My goodness.
I want to give that free workshop thing out to somebody. So, okay, everybody get ready. So whoever answers this question first is who I will give this to. What year was CPT born as far as the first CPT book?
Great question. Great question.
And as we are waiting to see if somebody answers that, I haven't gotten an answer yet.
Everyone's researching. All the coding professionals in the room are researching.
I just want to tell y'all in October, Stacy Buck is coming back on with me, and she's coming on with one of the VPs over at Maverick to talk about artificial intelligence in coding. So that should be a really interesting one. So be watching for the notice for that to come out with the invites, but that's going to be a good one to attend. Got some.
Oh, everyone is typing.
Amanda, I know she guessed 1983. It's a little bit older than that, Amanda. Oh, and the first one with the winning response is Anna here. It was 1966. That's when CPT first came out with the book. And I'll tell y'all.
Let me write down her name, Anna G.
Yes.
1966, just so you don't forget, Betty.
Yes, thank you.
Good job, everybody. Thanks for participating.
Good. Okay. And I'll tell y'all a secret. That's my birth year. So I'm as old as CPT.
Oh, that's awesome, Betty.
That's why I wish Amanda would have been right. So
it's a great try though, Amanda. That's a great try.
That's when I graduated high school. So, but yes, good. Yeah, Anna too, in LinkedIn, go ahead and message me and say, hey, this is it, because I'll need your email and things like that to be able to send you the links so that you can go get that free workshop attendance. And we will be very happy to see you next Saturday then. So that's cool. Great and wonderful. Thank you everybody for playing. So we'll try to, when I do things, I'll try to have little questions, trivia questions like that that go with coding. So good. Oh, and Teresa, here's another 72, but then she came back with, I just guessed. But it's interesting. So it's been that long. CPT's been around for quite a while. So yes, it's our good way of getting our stuff all done. So Sonal, before we wrap up, is there anything new going on with SP Collaborative, that like your latest podcast, that kind of stuff that you want to tell everybody about?
Oh my goodness. Well, other than the retreat I just attended out in the Hudson Valley, New York, beautiful experience. The 2 chapters that I'm speaking at next weekend, amazing. I'll actually be MIA for an entire week, the second week of October. And then I have a new podcast arm that's coming out. And we keep circling back, trying to release it, but it will be released and you guys will be the first to know because it'll be posted on LinkedIn, obviously. But Paint the Medical Picture podcast is still going strong. I just dropped an episode on Wednesday. This is my 3rd year, continuing onwards and upwards. So things like that. Yeah, I'm just slowly escalating, teaching, presenting. I'm actually talking for AMBA in November for the Lyles Parker team on TPE audits. So excited about that.
He's great.
And then, yeah, so there's lots going on. And then, of course, the NAMUS conference I'll be attending in December in Charleston, South Carolina. So hopefully many of you on this podcast can check out the NAMUS website, check out my posts that I contribute to on LinkedIn as well, because you can always use my discount code as well. And we'd love to see you in Charleston for a couple of days, learning the ins and outs of auditing and compliance, which of course we need to do as coding professionals in this new landscape. So yeah, I got lots going on, all my balls in the air, but I'm loving it. I'm loving it. So
Yes. So good.
yep.
Yes. So Sonal and I will both be at the NamUs thing. So if you go, make sure you come up and, start
And
talking to us.
say
We'd love to be
hello
chatting with
in
people. Yeah.
person. Yes.
And also, I just got a email before we went live that I'm going to be speaking at the Actis conference in April next year in Indiana. And Sonal and I know,
Yes.
Sonal and
And
I
then
will both be speaking for the Iowa AHIMA State
yes.
Conference in April next
That's right.
year.
That's
So
right.
yeah. So we're going to be hitting the road a little bit next year and this year, and so you'll be seeing us out and about. So make sure you're looking, watching on LinkedIn where we're going to be speaking, and what we're fixing to do, so y'all can keep up with everything we're doing. So thanks everybody for sending questions in and for joining us today and asking questions, getting real lively in the discussions. I love that. And we will have our, let's see, this is September, right? So
yes.
We'll have one more quarterly E&M, maybe if there's some different thing that comes out from the CPT symposium. This always gets interesting after that. So
yes,
in December.
Yes. Let's plan for one more before the end of the year. Yes, that's a great idea, because I have a feeling you're going to get a lot more information in November.
Yeah. Or when the final rule, when they come out and final say what they want, then we'll be able to talk more definitively about some of these questions. Yes.
That's right. That's right. Absolutely.
All right. So y'all, thanks a lot for joining us. We have had a wonderful, wonderful hour, and we will see y'all next time for our healthcare happenings, so that you can keep up on what is happening in healthcare. Bye, y'all.